join in. So welcome, good evening, everyone. Thank you for joining our presentation on current and future sarcoidosis treatments. For those of you that don't know, my name is Rhonda Jenkins. I am a program manager here at Cleveland Clinic's Sarcoidosis Center. I will be moderating this evening's festivities. And I just wanted to have a special note and thank you to everyone who was able to submit questions with the registration. We did receive quite a few questions, so I will be asking the presenters those questions at the conclusion of their slides and give them a chance to answer and reach out to everyone. I'd also like to note that this presentation is being recorded and we'll make that available to everyone who has registered as well as on our website following today's presentation. So for today, we have two presenters. We have Dr. Manuel Ribeiro, who will be presenting on the current treatments of sarcoidosis. Dr. Ribeiro is our director of the Cleveland Clinic Sarcoidosis Center. His focus is not only taking care of patients with sarcoidosis, but also clinical research and finding ways to better care for our patients. He'll be followed by Dr. Logan Harper, who is another pulmonologist in our Sarcoidosis Center. Dr. Harper will be presenting on future directions of sarcoidosis research. And Dr. Harper's clinical focus is also taking care of sarcoidosis patients, and his research focuses on improving care for disadvantaged patients. So now I will turn it over to you, Dr. Ribeiro.
Thank you very much, Rhonda. I really appreciate you organizing this again in this very important month of April, the Sarcoidosis Awareness Month. Thank you, Logan, for joining with me here. We'll do this together. And thank you all the attendees for joining. I see we just hit 100, 101, so this is great. I hope we have a very useful time here and we can all learn together. The first thing that I have to learn and do well is how to share my screen. So let's see if I get this right. Here we go. And Rhonda, can you see my slides there in presentation mode?
Yes, we can see your slides.
Good, perfect. So let me just get this out of the way. Good. So again, welcome everybody. Happy to participate, and I'll be happy to answer some questions at the end. But as you know, we'll be talking today about treatment of sarcoidosis. I'll talk about current treatments for sarcoidosis. But before we get there, before we get to this most important part, I have to talk a little bit about definition, what is sarcoidosis, and discuss a little bit about the pathophysiology, right? So how does the disease happen? Because this matters a lot for us to understand what treatments can we give. Within the treatment portion, I divided in three. So one, I'll give an overview of the current most common medications that we use, but then I'll focus a little more on some specific manifestations that you see, for example, cardiac sarcoidosis. And then I'll finish with some important slides, I think, on non-pharmacological strategies. So outside of medications, what else can we do? What can you do to feel better despite having this disease? So we'll go over all of that. As far as definition, this is an old definition from those important societies here, including the WASOG, but I think it's still very important for two reasons. One, it still stresses a very important point that sarcoidosis is a multi-system disease. So even though we are pulmonologists, right, we have to always remember this. And whenever we are treating patients with sarcoidosis, we have to have this holistic approach, and we try to do this on a daily basis. But the second important thing is we have to remember that we are dealing with a disease that causes those non-caseating granulomas, right? Most of you, if not all of you, know already what this is. And this matters because the medications that we use are targeting this process, this granuloma. And here's a picture of this granuloma, right? This is one biopsy showing what we call granuloma, this type of inflammation. We have a few cells in the center of this granuloma. We call them histiocytes, macrophages. They get together and they form those giant cells here. So all of those histiocytes and giant cells are in the center of that process, but there are other cells, lymphocytes, in the periphery. So this is important too, because again, all of those drugs that we'll talk about will be targeting those different cells. And here's another picture of this granuloma, right? You can see this a little bit better here, but the importance of this slide is to understand how this granuloma is formed. So what happens before this start? And based on research that we have today, we do believe that most likely this starts from some type of exposure in the environment. You can see those red bugs here, these represent antigens or triggers from the environment. Unfortunately, we don't know for sure what that something is. As you know really well, there are many possible culprits. We are still not targeting those antigens, those triggers. We can't tell, patients with sarcoidosis, avoid this exposure, that for sure you're going to get better. We do this in some other lung diseases, but unfortunately, we still can't do this in sarcoidosis. But what we can do is we can understand how our immune system responds to this. So what happens is those triggers from the environment, they are presented to this type of cell called lymphocyte, more specifically this CD4 type of lymphocyte. We can actually measure this lymphocyte in bronchoscopy samples, right? So we target these cells when we treat, and then those cells stimulate the formation of this granuloma by many different ways, but one important molecule or cytokine is this TNF, tumor necrosis factor. So some medications that I'll show you target this process right here. So by understanding this immune process, we can try to target this disease and make you feel better. One thing that is very important in sarcoidosis too is some patients, after they have this inflammation going on for a while, can develop scar tissue, fibrosis in different types of organs, lungs, heart, liver. And we are still trying to understand why that happens. Here are a few like fancy cytokines and letters and words here to try to understand how that happens. But again, as we advance in this research, hopefully we'll try to find more medications that can stop this process from happening. So moving on to treatment, the first point that we always make to our patients is not everybody needs medication. Sometimes the treatment is worse than the disease. This is very, very true in sarcoidosis. Here's a nice study from a colleague of ours, Dr. Judson, very, very famous in sarcoidosis, does a lot of important research. And as he showed here, only a percentage of patients with different types of sarcoidosis will require treatment. The most common one here, or the manifestation that most often requires treatment is the heart or cardiac sarcoidosis, 60% of patients needing that. But as you can see in some other situations like spleen or lymph nodes, that's much less, right? But even in the cardiac sarcoidosis, where most patients will need treatment, this is a recent document here. This is a nice paper that if you want to take a look at a recent guidelines on sarcoidosis led by Dr. Boffman from Cincinnati. And even in cardiac sarcoidosis, as you can see, all of those experts got together and said, we should treat only clinically relevant disease. So this is very important. As physicians, as patients, as caregivers, we have to be deciding, what in that disease is being significant here? Should we treat this manifestation? Maybe we should just watch that manifestation and not start patients on prednisone or something. So in heart, for example, heart block, arrhythmias, heart failure, those are the important things. But even in this situation, this is digging a little deeper in cardiac sarcoidosis, when to treat patients, we have to decide who are the patients that are likely to respond. Not only do they have significant disease, but if I give them prednisone or methotrexate, will they get better? And here are some tips that we use. First, if you have cardiac sarcoidosis, if our patients have cardiac sarcoidosis and they have heart block, they are most likely going to get treatment because this is the most likely manifestation to get better. Now, if they have arrhythmias, that's a little bit trickier. There's some studies suggesting that treating those patients with medications, with prednisone or something, can improve things. Some other studies showing that it doesn't improve it. So it's a little trickier here. We have to refer those patients to our friends from cardiology and maybe even consider sometimes like device therapies to treat those arrhythmias, like ablation, for example. So this is heart block, arrhythmia. Some patients, as you know, with cardiac sarcoidosis can have heart failure. So how do we decide in heart failure who gets better? So here I'm showing you two studies This one in the left is using cardiac MRI. This one in the right is using cardiac PET scan. So those are two studies that help us decide who benefits from treatment. Looking at this right one first, this is a graph showing the amount of inflammation on the PET scan. So the more to the right here, the bigger the inflammation in the PET scan, in the cardiac PET scan, and correlating that with improvement in the heart failure, in the ejection fraction from the echo. So as you can see, the bigger the amount of inflammation, the bigger the improve we can see in the ejection fraction. So this is one thing that we used to decide who needs treatment in cardiac sarcoidosis. Here, it's a little bit of the opposite. So in a cardiac MRI, what this is showing here, if patients have a lot of what we call late gadolinium enhancement in the cardiac MRI, more than 20, 30%, maybe this is all scar tissue and you won't really respond to immunosuppression. So this is what this study showed here. The bigger the amount of this contrast uptake in the heart, the lower the improvement in the ejection fraction. So we are always putting those things together and trying to decide which one of our patients we think will benefit from those medications. Once we decide together with the patients, right, together with you, it's always a team approach here, who will benefit from treatment. This is a general scheme that I like to use to think about what options we have. First line, steroids. Second line, I think any of those medications that, those are good options. Methotrexate, azathioprine, leflunomide, hydroxychloroquine, mycophenolate. If they don't work, or if the patient has a more severe manifestation, we can go straight to the strongest medications that we have, the third line agents, infliximab or adalimumab. As far as fourth line, I put a question mark here because there are no big studies, nothing proving what is the best fourth line in sarcoidosis. When we get to this point, we are basically trying newer medications that we learned from other diseases. I'll show you at least one of them today. So let's go step by step here and let's take a look at the steroids. So steroids help, many patients. Prednisone help many patients. This is one study combining actually different studies using prednisone in patients with pulmonary sarcoidosis. And as you can see from this graph here, to this side of the graph is favors steroids. So steroids did better. If you combine those studies, the steroids did a little bit better. And the outcome that they were looking at here was improvement in chest X-ray after 2 years, right? So more patients improved their X-ray after 2 years if they were on steroids. So we do give steroids, to patients, of course, with sarcoidosis. The problem is, as our group showed a few years ago, including Dr. Culver, steroids will give you a lot of side effects. So just by being on steroids, patients can have more diabetes, hypertension, obesity, dyslipidemia, osteoporosis, eye problems like cataracts. So, most of you have been through those things. We have to keep that in mind. Steroids can give you a lot of side effects. So we have to think of strategies to avoid steroids as much as we can. When we need it, we have to use it, but we have to think of strategies to avoid them as much as we can. Here is one of them. So in patients with pulmonary sarcoidosis, maybe you don't need to take prednisone through your mouth. Maybe we can do that as an inhaled therapy. And this is one study that showed this. 189 patients were divided into those two groups, steroids or no steroids. And they got steroids for 18 months and they did better actually. So lung function, chest X-ray, all of those things improved after 5 years. But here's the trick. Here's the key thing. Oral prednisone was used only for the first 3 months. And then the next 15 months was inhaled steroids, right? So we tried this strategy quite a bit if the only problem is pulmonary sarcoidosis. Here's another nice strategy. Let's say if you don't have, pulmonary sarcoidosis, but you have liver sarcoidosis. There's actually one medication called budesonide, which it is a steroid, but it acts primarily in the GI tract and the liver. It does not have all of those systemic side effects. So if the liver sarcoidosis is the main problem, we are always trying to treat our patients with budesonide alone. And then if needed, of course, later we can try other things such as azathioprine. Now, sometimes in some manifestations of sarcoidosis, like cardiac sarcoidosis, patients do need steroids. And look at this. This is a review study combining, again, many different studies. And look at the duration of steroids in those cases, right? You know this really well. Sometimes patients are on the steroids for months to years. So whenever this happens, whenever patients do need a longer course of therapy, what we do is we have to consider those second line agents early. So this is one thing that we do in our center. More likely than not, we're going to try some of those steroid sparing agents early so we can get you off prednisone as soon as possible. So I'll show you a few studies in those second line agents. There are not many, unfortunately, right? Sarcoidosis is an uncommon disease, and unfortunately, it's underfunded for studies. Many experts keep trying to fight that and try to increase the amount of research in sarcoidosis, but we still have a few studies. Methotrexate, for example, this is the only randomized study so far that I know in methotrexate. This was done by Dr. Boffman. And what he showed here, in a few patients only, very small study, but that the dose of prednisone went down on patients taking methotrexate. And we see this clinically. You know, we can taper down prednisone easier if we start patients on methotrexate. We use that quite a bit. Our group did a similar study on leflunomide, Dr. Sahu, Dr. Kover, and they showed that not only if we start patients on leflunomide, not only we can lower the dose of the prednisone much easier, but actually the lung function got better. So you can see here on the right side, the FVC, the forced vital capacity got a little better, the LCO got a little better. So we do use leflunomide, not only for pulmonary sarcoidosis, as you can see, some of those patients in that study had pulmonary sarcoidosis, but also for extrapulmonary sarcoidosis. Hydroxychloroquine, right? That's another medication that we use quite a bit, especially if patients have skin manifestations of sarcoidosis, joint manifestations, high calcium. Those are things that we are treating with hydroxychloroquine. Again, not a lot of the studies. This is a small study with 17 patients from the 1990s showing that skin lesions can get better if we treat patients with hydroxychloroquine. So we do treat patients with that quite often. Very well tolerated medication. The main problem is it can give you a problem in the retina. Less than 1% of the patients will have that, but it can cause vision loss. So you have to see ophthalmology before you start this, and you have to do a follow-up with them every 6 months, every 12 months, depending on their protocol. Now, let's say we want to treat sarcoidosis more aggressively, right? Either the second line agents are not improving the disease, or the manifestation is severe. Then we use infliximab. That's one of those TNF blockers acting on that very molecule, the TNF, that I showed you in that picture. That molecule is causing those granulomas to increase and to multiplicate. So it's important to block that molecule. This is actually one of the bigger studies that we have in sarcoidosis. So at least with this drug, we have a bigger study. This was led by Dr. Judson, Dr. Boffman. And two important things that they showed in that study. One, if you have pulmonary sarcoidosis that was not responding to other treatments, this can improve patients. So as you can see here, the pulmonary function test, the FVC, was a little bit better at 24 weeks, and chest x-ray also improved. So you see this improvement in pulmonary sarcoidosis. Again, we see this in clinical practice as well. But in the right side here, this is a score that physicians use in research, in sarcoidosis research, to decide if the extrapulmonary sarcoidosis is getting better. And the lower the score, the better. So those black dots here, those were patients on infliximab. And as you can see, that score of extrapulmonary sarcoidosis was also getting better on infliximab. As you unfortunately know this well, very tough to get this approved. This requires sometimes peer-to-peer reviews with insurance, phone calls, letters for appeal. But eventually, thankfully, we can get this approved to most of our patients. Our group, including Dr. Harper, he was the lead on this. You'll hear from him in a little bit, but he's amazing at doing important sarcoidosis research. So he took a look at our patients on infliximab, and he showed that we were able to decrease the amount of steroids in patients taking infliximab for cardiac sarcoidosis. But also, very important, the heart failure, the ejection fraction remained the same. There is this concern nowadays that maybe infliximab can make heart failure worse. We believe that if the heart failure is from sarcoidosis, this is not the case, and I think Dr. Harper was able to show this in his NICE study. Another type of TNF blocker, again, stronger medications, third-line agents that work on that molecule, the TNF. Another one is this adalimumab. Again, very tough to get it approved, but with the great team that we have, I think we're able to do that in most patients. It can take a few weeks sometimes, unfortunately. But this is one study that showed how useful that is. Again, small study, but at least it was randomized. So they sent patients to the adalimumab arm versus placebo or no medication, and look at the improvement in the cutaneous sarcoidosis. So this is actually one of the studies that I attached to my letters to insurance companies to try to get the adalimumab approved. And especially when patients have more severe manifestations of sarcoidosis, as I said, those medications, infliximab and adalimumab, they are important. This is one example of that. This is lupus pernio, a severe manifestation of cutaneous sarcoidosis. And this is another study showing the importance of infliximab in this manifestation. As you can see in this graph here, this here was the group of patients that got infliximab. And look at the white bar. Those are patients with resolution or near resolution of the lupus pernio. So you definitely need, this type of medication when you have the more severe manifestations, including lupus pernio. In cutaneous sarcoidosis specifically, if none of those things are working, we have a great team, and many centers do as well, of dermatologists to try local therapy. So topical therapy, intralesional injections of steroids, some of you had that already. So we try all of those things if our medications are not working. Some of you may have neurosarcoidosis, and specifically a subtype of neurosarcoidosis called small fiber neuropathy, right? So this causes neuropathy symptoms, tingling sensation, numbness sensation on feet, hand. This can cause body aches. This can cause sweating dysregulation. This can even cause autonomic dysfunction, so dizziness, a passing out episode, right? So all of those things can happen in this small fiber neuropathy. And the reason I wanted to include this in this talk is the treatment is very different. All of those things that I showed you before, prednisone, methotrexate, leflunomide, it's not going to get this better. In fact, leflunomide, one of the side effects is neuropathy. So we avoid leflunomide in patients with this manifestation. So if our patients have small fiber neuropathy, we actually try IVIG first. This is one study from Dr. Tavish, who was a neurologist in our team a few years ago, with Dr. Parambo. He was a big participant in this study, and Dr. Cover as well. And as you can see, most of those patients were on IVIG, and 76% of those patients improved symptoms on that. So we are always trying to get our patients approved for IVIG if they have small fiber neuropathy. Now, moving a little bit to that fourth line, right? So if none of those things work, we have patients on infliximab, adalimumab, methotrexate, and this is not working, we have to think of other things, other ways to treat patients. There are many options there, right? This area of fourth line agents for sarcoidosis is really uncharted territory. We can try cyclophosphamide. Some of you may be on rituximab. So all of those are reasonable options. But I wanted to show you this paper here on tofacitinib, because I think that at least in our group, this is probably the one that we are trying the most more recently. This is a different pathway of all of those other medications that I showed you. This is the JAK inhibition pathway. And this is like a new thing in sarcoidosis. A lot of research studies are focusing on that. And this pathway seems to be important for that granuloma formation also, right? So that's why we have been trying this in some patients with sarcoidosis. Here's one of the first and maybe most important publications on this medication. This was actually just one case report published in the most important journal that we have in medicine, the New England Journal. And that patient, as you can see here, had cutaneous sarcoidosis that was refractory to all of those medications: topical steroids, hydroxychloroquine, methotrexate, adalimumab. They even tried stronger immunosuppressants like tacrolimus. None of that was working. So they tried this medication, and as you can see here, the skin lesions improved quite a bit. And actually what happened was the patient got the medication for a while, and here's a score to check the severity of the skin cutaneous sarcoidosis. So on the medication, the disease got better. Then the insurance denied the medication. So the patient was off the medication because of the insurance for a little bit. So they were able to show that the disease got worse. Then they got the medication approved again. Then it was denied again. You know, it sounds like your life, right? Unfortunately, we deal with this quite a bit in our clinical practice. But this happened in this study, and they were able to show that this medication was helpful. So again, we are using this tofacitinib, 5 milligrams twice daily in some patients when we don't have a good response with the other medications. Now, another very important point. So whenever you've been treated for sarcoidosis, regardless of the medication, a very important question is, for how long do you need to be treated? The magic number is at least 2 years. You may have heard this quite a bit. And this comes from this Italian study from the 1990s, specifically on pulmonary sarcoidosis, that patients got treated for 2 years, and the rate of relapse after stopping the medication was about 30%. So we say at least 2 years. If there's still signs of activity after those 2 years, of course, we keep treating our patients. But the other important point to make here is, in some manifestations, including cardiac sarcoidosis, we are moving that line a little bit. And instead of saying at least 2 years, we are saying at least 3 years, maybe at least 4 years. I do think that for cardiac sarcoidosis, the longer the better, because there are some studies showing, including this one, small study here in the US, showing that the rate of relapse in cardiac sarcoidosis is higher than other types of sarcoidosis. So we do treat that for a little bit longer. I usually say at least 3 years. Now, moving on to the last part of our talk, which is other symptoms that patients have, that you have: fatigue, pain, concentration problems, memory problems, sleeping problems, symptoms that are not related to a specific organ, but are extremely important, affect quality of life, and we still need to treat. So we have a lot of patients with those problems. So usually I get questions about this, outside of those medications, what can we do to feel better? And I get a lot of questions on vitamins. And as far as vitamins, what I would say is the most important thing on sarcoidosis is actually not to take extra vitamin, but at least to avoid extra vitamin D if your disease is active. So I'm showing you here all of this, fancy algorithm for vitamin D, what happens in our body. But the important thing to know is, because, you have sarcoidosis, those granulomas, they have this enzyme here, and they activate vitamin D from the 25 vitamin D to 125. So patients on sarcoidosis, they can actually have a higher number of active vitamin D or 125 vitamin D, and they can get into trouble with high calcium, with kidney stones. So I tell my patients that vitamin D in the food or in the sun exposure, that's okay, but especially if the sarcoidosis is active, we should avoid those supplements. There are studies showing that just by having a prescription of vitamin D, as you can see here in this blue color, patients can have more hypercalcemia, including severe hypercalcemia. We always also get a lot of questions on diet, and I'm a believer here. I think this is extremely important, to have a healthy diet. It has been shown to be important in many diseases like heart diseases, and I think it's important for inflammation and for sarcoidosis too. You may have heard of this anti-inflammatory diet. There are studies on that in other inflammatory diseases like rheumatoid arthritis. Unfortunately, not in sarcoidosis yet, but hopefully soon this will change. But this, again, is a review combining a lot of the studies. And you can see that for this problem here of pain, this anti-inflammatory diet was better. The quality of those studies were not good, but again, I think this makes sense. Those were the Mediterranean diet, keto diet, vegetarian diet, basically avoiding red meat and animal-based products, avoiding sugar, stripped carbohydrates, think those things are bad for inflammation. And I think I usually tell my patients that this is a good idea. Exercise also is very good. We have one small study at least showing that exercise improves the quality of life in patients with sarcoidosis. You can see in this graph here, this is the St. George questionnaire. This is quality of life in sarcoidosis. The lower the score, the better. And as you can see that after 3 months of exercise, patients were feeling better, not only as far as quality of life, but as far as fatigue specifically. This is a fatigue score. And in the first visit, there was a significant improvement in the fatigue. The lower the score, the better. This first visit was 1 to 2 months after the exercise session, and the second visit was about 5 to 6 months after the exercise session. So the fatigue was getting worse again. So I always tell my patients, not only based on this study, but based on our experience, I think being active and doing exercise is very important. And last thing here, so I don't go over time too much, mindfulness in sarcoidosis. I'm a strong believer that this is helpful in everything, including sarcoidosis. And this has been shown in some other diseases. And there's, this nice study from New Orleans showing that this can be helpful in sarcoidosis too. This was a small study, 23 patients plus 3 family members, right? So important to include the family members in this discussion. And they did a 45-minute course on mindfulness, and they measured all of those problems here before the mindfulness training and after. And you can see here that we saw improvement in shortness of breath, in body aches, in fatigue and nausea. So I think those things are key as well. I'm right at 30 minutes, I think. So a last slide with a summary. Not everybody needs treatment. Sometimes the side effects are worse than the disease. Use alternatives to oral steroids whenever possible. If needed, stronger medications such as a TNF blocker should be used, but always remember that other strategies such as healthy diet, exercise, good sleep, mindfulness activities, those are important as well in inflammatory diseases, and I think it's helpful for sarcoidosis as well. So with that, I want to thank you all very much. Sorry, Logan, I think I stole 2 minutes of your time. But Rhonda, I'll be here, so I'll leave it up to you. We can do questions at the end. I'm totally fine. I'll be here as long as we need.
No, thank you, Dr. Ribeiro. I think we'll go ahead and I'll ask you a few questions we received with registration while Dr. Harper gets set up here with his slides. Thank you again for that wonderful presentation. You answered a lot of the questions we received, which is wonderful. 2 of the main themes that a lot of our questions came in around were about remission and then also side effects for some of the newer treatments. So can you elaborate on some of the side effects that you've seen with the newer lines of treatments?
Yeah, as far as side effects, I still think that the old treatments, like steroids, honestly, they are the worst as far as side effects. But of course, the newer medications, the second, third line, some of the fourth line agents, of course, they also have side effects. They are all immunosuppressant medications, so the rate of infection goes up a little bit. So we have to keep that in mind, especially with COVID running around. So this is always an important discussion to have with patients, this risk-benefit ratio. With those newer medications, liver inflammation is a little bit, it is more common than with steroids. So anytime that we put those patients in those newer medications, we have to monitor the liver function. You can develop more anemia and low, white count. So monitoring the lab work every month, every 3 months, I think that's important as well. But overall, I do think that the long-term side effects, especially of steroids, are worse than the newer drugs.
Thank you. The next question was around remission. So do you have any recommendations for patients who are currently in remission with their sarcoidosis, and how can they monitor their disease during remission? What are some things they should be looking for?
Yeah, I think I usually give 3 advices there because as most patients with sarcoidosis, thankfully, will go to into remission at some point. Sometimes it takes a few years, but this happens in most patients. I think the 3 things to know with remission is remember, of course, how your disease presented, because usually it will flare up in a similar way. So you have to keep that in mind. The second thing is some manifestations can develop even years after into remission, especially heart and neurosarcoidosis. So keep an eye for symptoms of cardiac sarcoidosis like palpitations, passing out, lightheadedness. If those things are happening even years after the sarcoidosis, that could be the sarcoidosis. And those symptoms of neuropathy, tingling sensation, numbness, they can happen years later. So keep that in mind as well. But the third thing that I tell my patients is, because it's a systemic disease, it can affect any organ of the body. Just talk to your doctor. If at any point you have a strange problem that you don't know what it is, talk to your sarcoidosis doctor and try to see if sarcoidosis could explain that problem.
Great. Thank you so much. Thank you. So now we can turn it over to Dr. Harper, and then at the end, we'll have some more questions for you both.
Okay, great. Am I unmuted? Everyone's able to hear me?
Yes, you're good to go.
Okay, great. Hello everyone. I am Logan. As Rhonda said, I'm one of the sarcoidosis doctors here at the Cleveland Clinic. And I have the exciting task of talking about where do we think sarcoidosis research is going to go in the future. And for this talk, the main thing I wanted to do was kind of explain how the process of scientific research worked, so that everyone could feel comfortable being included in clinical trials. Really, doctors and patients really work hand in hand for doing medical research, and I want to make sure that everybody's comfortable with kind of how that process works and how we work really hard to protect patients through the process. So first, I want to talk about kind of how I think of medical research progressing through kind of three major stages. That is epidemiological research, followed by basic science research, followed by clinical trials. After talking through that, I want to talk about a few drugs that are in the pipeline, and talk about how one of those drugs got into the pipeline as an example. And then I want to close out with how patients, if they want to, could get involved with research. So epidemiological research is really just studying populations and looking at what sort of exposures or risk factors are linked to disease, or what sort of exposures are linked to better health. Knowing this can give us hints on how a disease works, so that we're able to figure out how to turn that into an effective treatment for our patients. There are a lot of different types of epidemiological research. Kind of the most common is a cohort study. In a cohort study, what you do is you find two groups of patients, one who have been exposed to some sort of risk factor, and a second group who isn't. You follow them and you see what sort of disease develops. An example of this would be if you wanted to figure out, are people who drink coffee more likely than people who don't drink coffee to develop lung cancer? So while this is a really helpful way of learning what risk factors are, it's often really hard to tell if these associations are causal, or if they're just happening due to some other factor that we're not measuring. An example of this would be, you could see that if in our study where we were looking for if coffee was associated with lung cancer, if we recruited from this restaurant, where it seems that people who are drinking coffee are also are also smoking, we might get very different results than if we recruited from this restaurant where no one's smoking. We call this problem in epidemiological research bias. If you talk to an epidemiologist, they will wax poetic about dozens of different types of bias. And there's really two main ways that we work on controlling bias. The first is we make sure that when we are choosing a group of people for our epidemiological study, we really want to get a wide range of patients. That makes it so we are less likely to run into the situation where we accidentally recruited patients who all have something very particular in common that'll make it so our results are confusing. The second thing I want this to highlight for us is how epidemiological research isn't the end point. This gives us hints, and it's very important that after we discover some sort of association, we make sure that we then figure out why that association is there. And that's when we move from epidemiological research into basic science research. One thing I wanted to say, in sarcoidosis, we have multiple patient registries out of there. One of the biggest that I am aware of is the FSR SARC registry. Registries let us do high quality epidemiologic studies for diseases that are relatively rare, like sarcoidosis. By having sarcoidosis answer questions and tell us what symptoms they have, what treatments they're on, what sort of exposures they have in their life, we're able to gather all of this data that lets us design better basic science and clinical trial studies. So after we've done our epidemiologic research and we found some sort of exposure, we then want to go into the lab and figure out why is that exposure causing this problem. Basic science has a lot of tools. Most of them are focused on either exposing cells to different chemicals or proteins, or taking proteins away from cells and seeing how that changes how they act. Basic science is probably the research method where patients have the least exposure, because we're often able to do this with cell lines that are developed in the lab. There are some cases where we ask patients, "Hey, we're doing a biopsy for your health. While we're in there, could we take extra tissue to do basic science research?" And these are the questions that those samples would be used to answer. How are the cells talking to each other? What do all of the different proteins do? And our goal by doing that is to identify targets for new drugs. So we talked earlier about how when you do a cohort study, it's really hard to tell if the exposure is the cause of the outcome that you see. And this may cause you to ask, okay, if you can't tell if exposures are the cause, how do you prove that a drug is really what's causing improvement when you give it to someone in a disease and it isn't due to something else? The answer to that is randomization. So during his talk, Dr. Ribeiro mentioned a couple times that studies had been randomized. The goal of the goal of randomization is to take a group of patients and split them in half randomly. By doing that, we hope that any any associ any association to any other factors such as age, gender, what they're eating at home, where they live will be lost because we have shuffled the deck, so to say. After we've done this, we're able to give one group the potential new treatment and the other group the standard treatment that they would get usually. After we've done this, any difference we see between the two groups, we can attribute to the drug rather than any of the other rather than some other factor that we aren't aware of. Another component of clinical trials that sometimes gives patients pause is called blinding. In his talk, Dr. Ribeiro mentioned a placebo a couple times. When we do a clinical trial, it's really important often to make it so the doctor giving the treatment and the patient getting the treatment doesn't 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 know if they're getting the study drug. We do this because of the placebo effect. I think many people have heard of this, and this is the case where if you give someone any sort of pill, even if it doesn't do something, it'll usually make people feel a little bit better. This slide from the journal Nature shows some of the reasons why we think that happens. When people are given treatment, they are given a sense of confidence that they're gonna get better. They're given extra care by their doctor if the doctor's actually administering the drug. And there's also a lot of feelings that people have when they're given something to treat them. It can reduce anxiety. It can make it so people are more able and willing to exercise because they have hope that they're going to be feeling better. I go over this because I've sometimes had patients, when we talk to them about trials, be a little uncomfortable with the idea of blinding. And I just want to make sure that everybody knows we're doing this not to deceive people, but to make it so we're able to see how well the drug works and make it so there isn't any bias. So having kind of gone through that, I want to highlight a couple drugs that have clinical trials registered. You can go to clinicaltrials.gov, and you can just search for sarcoidosis and see trials that have been registered. There is a small randomized controlled trial for using a drug that blocks interleukin receptor 1, one of those mediators that can cause inflammation. There's also a randomized controlled trial that I don't believe has started yet, looking at interleukin 18 blocking for pulmonary sarcoidosis. There's also trials for non-medical drugs. As Dr. Ribeiro said, mindfulness is very important in the healing process of sarcoidosis and making sure that people have the ability to overcome the feelings of fatigue. So there's actually a clinical trial working on getting started using a smartphone app to guide patients through mindfulness, and they're going to see if that can really help patients fatigue. As Dr. Ribeiro also said, we're not quite sure what to do with vitamin D in patients whose sarcoidosis isn't active and their vitamin D is really low. So there's actually a clinical trial starting. I don't see that it is actually recruiting patients yet. Looking at does giving vitamin D supplements help sarcoidosis patients? So I want to take the study on interleukin receptor 18 blocker and kind of show how this drug got into the pipeline. It started off with some epidemiologic research. They had a group of sarcoidosis patients here, and then a group of controls, which is what we call patients who don't have sarcoidosis in a trial like this. And they showed that interleukin 18 levels were higher in the lungs. This study is helpful, but we don't know from this, is the interleukin 18 being higher actually causing the inflammation? So the next step was basic science research. In this research, they took a cluster of cells and they gave them interleukin 18, and they showed that this AP1 protein, which is a protein that causes inflammation, became much stronger after given the interleukin 18. That isn't the only study on interleukin 18, but I think it kind of shows the type of studies that are necessary for us to develop these flow sheets that show, we think, some sort of inorganic particles trigger the body to form all of these proteins and trigger the inflammatory process, which causes the granulomas. So now that we have evidence that interleukin 18 may cause the inflammation in sarcoidosis, the next step is a randomized clinical trial where half of the patients will be given a drug that blocks interleukin 18. The other half will be given standard sarcoidosis treatment, and the goal is to see which group does better. So I hope that's kind of highlighted how this process works, how we start out seeing that there is some sort of association. We then go into the lab and figure out a plausible molecular pathway where that association could be causing or improving a disease, and then we look for drugs that would target the proteins in that pathway. And only after we've done all that will we offer a clinical trial to patients. And this is because we really value our patients, and we know that using a drug that hasn't been fully proven is something that we need to make sure we've done every possible piece of homework first, so we make sure that we are helping people. So after hearing that, you may ask, how could I get involved? If you're interested in participating in an epidemiological study, you could participate in the FSR Sarcoidosis registry. I've put the website over here. You can also just Google FSR Sarc and it pops up really near the top. You can also ask your doctor if they are aware of any clinical trials that you could participate in. And then if you wanted to cast a little bit of a wider net, the FSR website actually has an area where you can type in some data about yourself and see if you qualify for any nearby trials. So with that, I want to open it up for questions.
Thank you so much, Dr. Harper. That was really helpful. We had a lot of questions folks submitted around COVID-19 and sarcoidosis. Are you able to kind of talk about, can COVID-19 trigger sarcoidosis, or can you discuss the interplay between COVID-19 and sarcoidosis?
Yeah. So this is definitely a place where we're still in the epidemiological research sphere. So I can't tell you why, but what we know is there have been multiple studies where it doesn't seem like just having sarcoidosis is a huge risk factor for developing COVID. It does seem that being on an immunosuppressant drug for sarcoidosis would make the COVID vaccine less effective and could make people more likely to develop COVID. There's also been scattered reports of people developing COVID and then developing a granulomatous response that looks like sarcoidosis. I can't say how much of that is due to chance. People develop sarcoidosis every day, and millions and billions of people caught COVID in the last year. So it could have happened by chance. But anecdotally, I've had sarcoidosis patients who tell me their sarcoidosis feels a little bit more active after the COVID. It's tricky because a lot of the long COVID symptoms look like sarcoidosis symptoms. We're seeing people after COVID having pain, having pain and fatigue and shortness of breath. So I think what I can say is I wouldn't be surprised if we find out that having COVID can trigger sarcoidosis. I can't tell you what the chance is. So I can't tell you if you caught COVID, what's your chance of your sarcoidosis getting worse. The most important thing I can tell you is being vaccinated works for patients with sarcoidosis. There isn't any contraindication for sarcoidosis patients getting vaccinated. So I definitely think it's a good thing for sarcoidosis patients to be vaccinated and minimize their chance of having COVID issues. Anything to add to that, Dr. Ribeiro?
No, nothing to add. I agree completely.
Thank you, Dr. Harper. We had a lot of questions also in the wellness realm, and I know you and Dr. Ribeiro both touched on vitamin D and its effects on sarcoidosis. What other supplements should patients either avoid because of their sarcoidosis, or supplements that you found helpful to the disease?
In general, I haven't found supplements to be particularly helpful. The anti-inflammatory diet is something I definitely recommend to most of my sarcoidosis patients. I think we have a lot of data that that having a healthier diet, a healthier weight, and exercising will improve symptoms in sarcoidosis. Right now, I'm not aware of any any good data for supplements improving symptoms in sarcoidosis. Has that been your impression, Dr. Ribeiro?
Yeah, it is the same impression. And one more point also to clarify on the vitamin D, because Dr. Harper mentioned this really well, right? So there's that study looking at vitamin D supplementation in inactive sarcoidosis. So it's an important point. We avoid the vitamin D supplementation if the disease is active, because we think that that can cause problems. But a lot of times, the disease is inactive, and then you have vitamin D deficiency and maybe bone issues like osteopenia, osteoporosis, and your physician wants to replace that. So in that case, if the disease is inactive, then we are okay with that supplementation as long as you track both 25 and 125 vitamin D every 3 months or every 6 months. So I think it's nice that we have a study like that exploring that.
Great, thank you. And I know we're getting close to time, but we had one question around another category of question around genetics. A lot of folks talking about having multiple cases of sarcoidosis in their families, being a mother, they're worried about their daughters or their children having sarcoidosis. Can you talk a little bit, Dr. Ribeiro, on the genetic links or what that could look like for patients?
Yeah, a couple things about genetics. Maybe three or four points. One, so sarcoidosis is not like a strong genetic disease in a way that you'll pass that to your kids, right? So this is a good thing. Like the kids don't need to be tested. So this is an important point to make. Of course, if in the future, if anybody develops symptoms and has a relative with sarcoidosis, it's important to mention that to their physicians. But there's no testing that we need to make. Now, the other thing kind of related to genetics that is important is, I told you that we believe that the cause of sarcoidosis is the exposure to something in the environment, right? However, more and more research studies are showing that it's not simply the environment, it's the environment plus a genetic predisposition. So it's not a genetic disease that you'll pass along to your kids, but some patients may have specific signatures in their genetics that predispose them to sarcoidosis. And it seems like there are specific matches, like one genetic predisposition to this trigger developing like cardiac sarcoidosis, right? So this has been shown with pesticides, for example, a specific genetic predisposition to cardiac sarcoidosis if exposed to pesticides. So I think for now, there's really nothing that we do from a genetic standpoint for sarcoidosis, but in the future, when more studies are done, like Dr. Harper was showing, more medications are being developed, maybe people will be looking more for this interaction, between the environment and some genes. Now, the last thing that I would say is there is an even more uncommon type of sarcoidosis that happens in kids. It's called Blau syndrome. So this is genetic, right? But this is a different disease. It's early onset sarcoidosis from a specific mutation causing this Blau syndrome. This presents very early in life, so it's not this sarcoidosis or this disease that we're discussing here today.
Great. Thank you so much for that explanation. So we are 2 minutes over time. I want to thank both Dr. Ribeiro and Dr. Harper for your time and your presentations. You both did a wonderful job. I want to remind everyone this presentation was recorded, so we will be sending this out to everyone who has registered. And then we're also going to work to get it put up on our website in the next few weeks. So don't worry if you didn't catch everything tonight. Also, we'll be sending out our center's contact information. I know a few of you had really specific questions to your own case of sarcoidosis. We want to make sure those get answered and you're able to get into the center to see us, or we recommended for a center closer to home. So thank you, everyone, and have a great evening.
Thank you, Rhonda.
Thank you very much, Rhonda, for organizing this. This was great. Thank you.
Thank you both. Take care.